There are certain prerequisites that must be met before brain death testing can take place. We have all heard of the person pulled from the ice-cold river, apparently dead, but brought back to life after a prolonged period of time. We've all heard of people allegedly being declared dead, waking up from drug overdoses days to weeks later. What is important to note is that none of these cases could have been certified brain dead because testing would not have been accepted. Required preconditions were not met. But what temperature is adequate? How are drug effects excluded? How do we know this is not some weird medical cause of coma that a Dr. House or TV super doctor could solve in the nick of time? The prerequisites for brain death are that the cause of the coma must be known and be irreversible. The most important factor before declaring someone brain dead is the establishment of an unequivocal cause for the individual's unconsciousness. The patient must be normothermic, having a temperature above 35 degrees centigrade. This is important because people have been successfully resuscitated after prolonged immersion in cold water. This is because the cold slows down the body's need for oxygen and they go into a sort of hibernation. Doctors use this to the benefit of patients during cardiopulmonary bypass to buy themselves more time to operate. Therapeutic hypothermia has been used as a rescue measure in patients who have had a cardiac arrest who recover spontaneous circulation but do not regain consciousness immediately. In cases where hypothermia has been deliberately induced, the patient should be made normothermic for 24 hours before brain death testing can be considered. The patient must also have an adequate blood pressure during brain death testing. For an adult, this is a systolic pressure greater than 90 millimeters of mercury or a mean arterial pressure greater than 60 millimeters of mercury. Low blood pressure is a cause for immediate intervention by doctors and indicates a severely unstable patient. Brain death testing in such a patient who needs ongoing resuscitation is inappropriate. These patients need intravenous fluids, blood products, or drugs, typically vasopressors, to improve their blood pressure. The patient must have all potential drug effects excluded. This starts with a careful history and a review of the patient's notes. Drug metabolism depends on the total dose, the duration of treatment, the age of the patient, and underlying liver and kidney function. Central nervous system drugs, such as opiates, benzodiazepines, and barbiturates, as well as neuromuscular blockers and anticholinergic drugs, can mimic a brain-dead state. In cases where these drugs have been administered therapeutically, recreational, accidentally, or even deliberately, there are various ways to exclude their effect. One option is to delay the brain death testing. Pharmacokinetic studies tell us that the drug levels decrease exponentially. A time period that is 4 times the drug's half-life is accepted as the point where there is no residual effect. For example, a dose of 10 milligrams of midazolam given to intubate a 40-year-old 70-kilogram adult, waiting 12 hours is considered adequate in the setting of preserved renal and hepatic function. Another option is to use a specific antagonist or antidote to reverse the effects of a particular drug. For example, flumazenol can be used to reverse benzodiazepines, and naloxone can be used to reverse opiates. A nerve stimulator can be used to exclude the effects of neuromuscular blockers. The final option available is to check drug levels in the laboratory. This is advocated for cases where intravenous barbiturates have been used due to their particularly long half-life, which can be up to 80 hours. In cases where the laboratory testing is required and is not available, brain death should be confirmed with ancillary testing. Finally, there must be no metabolic or endocrine cause for the coma. The patient must be adequately ventilated with normal carbon dioxide and oxygen levels. This is checked with an arterial blood gas measurement. The partial pressure of carbon dioxide must be less than 6 kilopascals, and the partial pressure of oxygen must be greater than 8 kilopascals, with a normal blood pH. The blood sugar must also be checked. As this can fluctuate markedly during critical illness, it must be checked immediately prior to brain death testing. A level below 3 millimoles per liter or a level above 20 millimoles per liter must be corrected. Electrolyte disturbances often occur in brain-dead patients and must also be corrected. This can be secondary to brain death itself. For example, with brain death, the hypothalamus stops secreting the hormone ADH. This results in kidneys being unable to concentrate urine, a condition known as diabetes insipidus, and as a result, serum sodium levels start to climb. Hypernatremia in this setting can be difficult to fully correct. A sodium level lower than 115 or above 160 can cause CNS depression, and if the primary cause of the coma is unknown, must be actively addressed. Remember, overly rapid correction of sodium levels can cause brain damage itself. Other electrolyte levels, such as a severely low potassium of under 2, or low or high magnesium or phosphate levels under 0.5 or greater than 3, can cause flaccid paralysis and must also be corrected. Low or high thyroid hormone levels or adrenal insufficiency may also cause weakness preceding to encephalopathy and coma. These conditions are extremely rare and unlikely to coexist in the presence of known primary pathologies. If there is any clinical reason to expect these disturbances, then it is obligatory to ensure the appropriate hormonal blood tests are undertaken. Let's look at a clinical scenario to recap. You have a patient who has had 2 CT scans 48 hours apart, which have been reported as normal, but the patient is 5 days in ICU without waking up. There is no evidence of any brainstem reflexes, and the patient makes no effort to breathe. What would you check first if you were consulted to give your opinion? I would review the cause of the patient's condition, check that the patient has a temperature above 35 degrees, check that the patient's blood pressure is normal. I would try to exclude all drug effects, possibly by doing a full laboratory screen, and I would check for electrolyte, endocrine, and metabolic causes with additional blood tests. All prerequisites must be met before commencing formal brain death testing on anyone.